Just because it's called foot drop doesn't mean you should start at the foot. In fact, the foot is one of the last places I look at. See, when a patient walks in with a foot drop, whether it's neurological, orthopedic, or even post-surgical, people immediately think, tibialis anterior, strengthening, electrical stimulation. But over the years, I've realized something. The foot is where you notice the problem, yes, but it isn't always where the problem actually begins. So before I even assess the ankle, there is a checklist I run through. So first is the trunk. Can the patient maintain proximal stability? Because without proximal stability, distal controls becomes much more difficult. And then the pelvis. Can they transfer their body weight efficiently? Or is poor weight shift changing the entire gait pattern? Third, the hip. Can the limb advance during the swing pace? Fourth, the knee. Is there enough knee flexion for the toe clearance? If not, what's actually limiting it? And now I ask, is it a true dorsiflexor weakness? Is plantar flexor spasticity restricting the movement? Is selective motor control impaired? Is sensation affecting the foot placement? Or has the patient developed a compensation that's become their normal? You see, because foot drop isn't a diagnosis, it's a sign. And the treatment completely changes depending on why the foot isn't clearing the ground. So next time you see a foot drop, don't immediately think, tibialis anterior. Instead ask, what's actually stopping this patient from clearing the foot? Because once you identify, the real problem, the treatment becomes much clearer. So in my next reel, I'll show you exactly how I choose the treatment, based on what I find.